It's a shame that President Trump's Opioid Commission said little about demand-side prevention. That's the topic of this week's Healthcare Triage. Special thanks to Austin Frack, from whose Upshot column this episode was adapted. Prevention is a lot less costly, both in dollars and in lives disrupted, to stop opioid misuse before it starts than to deal with its aftermath. And many prevention programs are cost-effective, according to an analysis by the Washington State Institute for Public Policy. The report from the Commission last month emphasized limiting supply much more than demand, targeting opioid sources like prescriptions in the black market. That's important too, but among the report's 56 recommendations, only 2 aim to prevent people from seeking out opioids for no medical purpose: an advertising campaign and a structured discussion with a health professional. Neither approach has particularly strong science behind it. The other demand-side prevention approach recommended by the Commission isn't a lock either. The approach, called Screening, Brief, Intervention, and Referral to Treatment, or SBIRT, begins with an assessment to identify people who may already be engaged in risky use of opioids or other substances. This could occur during a regular doctor's visit. Those found to be using drugs in high-risk ways are given advice and feedback or referral to treatment if warranted. This could prevent progression to worse outcomes of opioid misuse like addiction and overdose, but wouldn't prevent misuse of opioids before it starts. Though this screening referral approach has been applied to patients of all ages, the report emphasizes its use in school-based settings. It draws examples from programs in Massachusetts for middle to high school students and in Ohio for college students. This leaves out useful prevention programs for younger children and older adults. It's worth engaging these populations too. Though few children below middle school age use or misuse opioids, some programs aimed at them can prevent their use at older ages by identifying risk factors and countering them. For example, a favorable attitude towards substance abuse, either within the family or by children directly, increases the risk that a child will later get into trouble with addictive drugs, tobacco, or alcohol. Other risk factors are family conflict, poor peer relationships, or difficulty in school. Community characteristics like deterioration of physical infrastructure, high rates of mobility into and out of the area, and easy availability of opioids are also risk factors. To counteract those risks, these programs aim to increase protective factors, such as meaningful involvement in school, family, or community activities, recognition for achievement, coping skills for dealing with stress and emotions, and a social environment that conveys an expectation of not using drugs. There are evidence-based programs that address risk and protective factors even for young children. The Nurse Family Partnership sends nurses on home visits with first-time mothers. The visits include education to improve pregnancy and infant health and development and to strengthen parenting skills. One randomized trial of the program followed children for 12 years and another for 15 years. Both studies found that the program reduced a host of problematic behaviors, including those related to drugs and alcohol. Another early elementary school-based program, the Good Behavior Game, also has some solid science behind it. The program rewards children for good behavior during classroom instruction. A randomized trial found it reduces rates of alcohol and drug use in young adulthood among males. Another test involving the Good Behavior Game shows it reduces use of cocaine and heroin. By strengthening basic capacities of emotional management, social skills, decision-making, and social connections to parents and community, programs like these help children and teenagers avoid drug misuse. But they also help with everything else in their lives too. In this sense, we make a mistake when we think about preventing drug use as separate from addressing problems like bullying, dropouts, or even suicide. Providing children from a young age with certain basic skills and connections can help address all these issues. Other programs from middle to high school age students have solid evidence of effectiveness, particularly ones that engage entire communities in a shared effort. For example, the Communities That Care program builds coalitions in a community and provides tools to make decisions about the best evidence-based prevention programs. A randomized trial across 24 towns that followed about 4,000 children from 5th to 12th grade found encouraging results. Children in the Communities That Care program were a third less likely to take up alcohol or cigarettes in middle school, making them less likely to progress to other drugs, including opioids. Parents are important too, of course, and there are evidence-based drug use prevention programs that involve them. One program, the Strengthening Families program, for parents of youth 10 to 14, aims to enhance parenting skills and adolescents' ability to refuse drugs. Several studies found it reduces alcohol and drug use throughout young adulthood. Finally, we should not overlook adults. Most drug experimentation occurs in young adulthood. In 2015, nearly 40% of adults in the United States reported using prescription opioids. Such use is most often for medical purposes, but 5% reported misusing them and 1% had use disorders. For these people, workplace drug testing is a worthwhile approach. When the Department of Defense made drug use grounds for potential dismissal from service, positive tests fell. The rarity of drug-caused accidents in industries that test employees, like aviation, further suggests that this is a good strategy in some cases. There are many evidence-based prevention programs that could be usefully applied to the opioid crisis. The Commission's report mentions some, including many of those described here, but it stops short of recommending any. We like to make videos about sometimes controversial topics like drugs or sex and stuff like that YouTube doesn't want to sell to advertisers. And that's fine, because we care more about the content than we do about the money. That said, any help you can give us to help make the show bigger and better is also appreciated. And one way to do that, maybe the best way to do that, is through a subscription service called patreon.com. You can go to patreon.com/healthcaretriage, make any donation you like, $1 a month. All of it goes right to the show and helps us make the show bigger and better. Finally, we're getting to the end of the year. It's gift-giving time. What would be better than Healthcare Triage merch? Mugs, lunch boxes, posters, little key fobs, hctmerch.com, and of course, my new book, The Bad Food Bible. Best gift you could possibly give this year. Go buy a copy now.